Well, good morning, Dr. Spurrier. Thanks for joining us today here at this IPAA on the couch. Can I start by acknowledging the land we meet on today as the traditional lands for the Kaurna people, and we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the traditional custodians of the Adelaide region, and their heritage beliefs are still important to living Kaurna people today. Can I also acknowledge the IPAA team and major partners, including PwC and Flinders University, the Office of the Commissioner for Public Employment Leadership Academy, and the Government Senior Management team. And thank you, Dr. Spurrier, for spending some time with us, given your incredibly busy schedule. So New Year's Eve, you would have been sitting there with a glass of bubbles or some description, and have someone said to you, this is your next 6 months, would you have believed them?
Probably not, but we are always planning for pandemics. So as a public health physician, of course, this is on our radar, and we have had previous problems with respiratory viruses, and we have problems, obviously, with people with meningitis and TB and all sorts of infectious diseases. So it wasn't completely off the radar, but I don't think anybody in the world had anticipated the impact of COVID-19, and it has certainly been just almost the entire focus of our health department since that time.
How regular are a novel coronavirus? How regularly do they appear? And is this something that happens all the time, but this one's just particularly virulent, or is this a rare event as such?
So people will remember we've had swine flu and SARS and MERS. So it is just part of the biology of viruses to mutate. And so there's always this risk when you've got, particularly as the world's changing and the ecology of the world's changing and humans are having more of an impact on the natural environment, that you will get crossover between viruses that are circulating in a animal population and then can pass into a human population. So it's not unexpected. And in fact, if you ask me a question, why did we do so well in South Australia? It was actually because we have one of our clinical microbiologists at SA Pathology, Jeff Higgins. I was told that he had been planning for a pandemic for the past 10 years. And so he, as a clinical microbiologist and particularly a virus expert, had known that this would occur at some time. It wasn't if it was going to occur, it was when it was going to occur. And so he had everything ready to go, and that's why we were able to get our testing up very quickly in South Australia. Not just to be able to do the test, but to scale it up so that we could have a large number of people being able to access the test at any one time.
Right, and was that common across the country, or is that specifically in Adelaide?
That was specifically in Adelaide.
Okay.
So we had our public pathology laboratory, so it might not be something that perhaps private laboratories would have been thinking of because it's obviously a different business model, but we've always worked very closely in our public health unit with SA Pathology, and so they appreciated that we would need this capability.
That's really interesting. And how much more do we know in July 2 than we knew on January 1 about the virus and how it acts?
Oh, we know so much more. Yeah. So we didn't know very much about the epidemiology. We didn't know how transmissible it would be, so how readily it would spread to other people. We didn't even really have much information about the incubation period. We were having to make guesses about those sorts of things. So we know a lot more. We also know that it can change its genetic composition. And for example, in Victoria at the moment, they've been doing all of the genomics on all of the cases that they've had and been tracking, and doing that, you can track whereabouts did that strain come from. Now we've done genomics on our cases as well. It's very helpful when you're trying to link clusters together. But of course, now that we haven't had any cases here for quite a long period of time, we haven't needed to use that capability.
When you came into the role mid last year or like last year, obviously there was a plan to a degree. How hard or how much work went into sort of the January, February preparing for, this became, I guess, more public for most people in March. It was obviously the travel ban from China in mid-February from memory. but it really became very real for a lot of us when things started to be shut down. How much work went into that period in sort of January, February, as you could start to see this really develop?
Well, we were working around the clock. We were doing 12, 14-hour days. We're working over the weekends. We are lucky that we do have a good team, but it's small and agile, and the ability to ramp that up quickly has certainly been a challenge. So there was a huge amount of work being done, more or less behind the scenes. I think also, just to say nationally, as a Chief Public Health Officer, I've been meeting almost every day. We're now getting a few weekends off with the other Chief Health Officers as part of AHPPC. It's a 2-hour meeting every day at the same time. That has been absolutely critical. That keeps me up to date with the latest information around the world, around Australia, but it's also that collegiality. But it obviously takes up a lot of time and effort as well.
You're talking about learning from the virus as we go through. How much is that group, the national group, learning from outbreaks in the United States and India and other places where there isn't as much control over is that?
Oh,
informing?
Absolutely, totally informing. We've got a number of really fantastic academics on the group. We've got a group of people, mathematical modelers, that are producing models for us on a weekly basis down to all of the different jurisdictions. And I've also been very lucky to have SAMRI, Caroline Miller from SAMRI, one of the professors there, is helping. If I have a question, she can pull the evidence together for me, because obviously, there's a lot of information, and it's also trying to work out what is relevant and what is correct information. One of a good example of that was very early on. People, I don't know if you'll remember, but there was a case of a woman from China who'd gone to Germany and was giving a workshop. So it might have been to engineers. It was some sort of industry workshop. And a number of those people became ill, and the media had reported that she had completely had no symptoms. And so we were then thinking, this must be evidence of asymptomatic spread. And started wondering whether we should be basing policy on that. In actual fact, once that had been published in a medical journal, it became clear she did have symptoms, but she'd been taking Panadol or whatever to sort of mask the symptoms. So it wasn't until they got the information from her directly in China, had that sorted out, and they published it in a peer-reviewed journal. So one of the challenges has been getting initial reports. The same with hydroxychloroquine. There was this initial report that might be useful, but not just taking a little bit of time to make sure that we had looked at absolutely all the evidence and see whether it's watertight or not.
Which leads to sort of the question that most people would, I'm sure, be asking you, which is, where's the vaccine and where's the treatments? What's the latest in your mind in a balanced way about where we're at?
So, Jamie, I can honestly say that I'm not looking at that literature at the moment because it is too far off. So there are a number of candidate vaccines, and there's been a lot of work in Australia setting up, making sure we're set up so that once there's a vaccine, we can trial it here, and we can also scale up the production. But that's actually not at the front of my mind, and I'm not spending too much energy on that side of things. What I'm spending energy on actually is really watching what's happening in Victoria and planning for that to happen here in South Australia. So to be perfectly honest, we've done really well here, and it's been fantastic to lift the restrictions and see businesses opening again. But the reality is it hasn't gone away. And so we are very much in that planning phase at the moment.
So you're working to the expectation that for some period of time, be it 6 months, be it 12 months, this will be our life.
We are not going to be back to normal. We're going to be COVID normal. And hopefully that's still livable, I think. And one of the things that has really troubled us as public health doctors is we know that it's impacted the economy and individuals, and it had significant impact on mental health, and social and economic factors really affect people's health. It's a key driver of health. So being able to walk this fine line between having restrictions but allowing some normality. But unfortunately, I can't say we are back at normal. It's COVID normal.
Yeah, and that it's an interesting question, isn't it? Because presumably when you came into this role, one of the things that was front of the public health discussion, issues like mental health, issues like pressures on certain demographics in the community and so forth. They've been amplified, of course, as businesses have been impacted so significantly,
yes.
and will be, when things like JobKeeper and so forth are removed in the second half of this year.
Yes.
How do you feel about that aspect of this tension? I mean, it's not your job to look after the economy as well as the health, but long-term youth unemployment causes lots of public health problems.
Oh, absolutely. I mean, I think it really is difficult. However, I'm quite a positive person, and there have been some silver linings, and there's also been, to me, the way that South Australia's come together as a community. We've had some really innovative things happen in South Australia, and I think this will go on to how do we run things, how do we do things in a way that's COVID safe, but it's still, we can still enjoy the things that we used to do. There's many examples of that. For example, with the Adelaide Oval, we perhaps thought, oh, gee, having a large number of people together, this is going to be very difficult. But actually, if you think it through, and the Adelaide Oval management had really understood what needed to happen, then we could do it in a COVID-safe way.
Is the path for further reductions, do you think, or is what we're at right now as far as the transition committee, where we'll be at for the next 6 months or so?
Yeah, that's a really good question, and we're looking at messaging around that. We are where we are aiming to be. So this is COVID normal, yeah. And so at the moment, one of the other things that we're doing in our planning is assisting more risky businesses to develop COVID management plans, and that's one of the jobs I'm doing this week, is getting all of that up and organised. Yeah.
Being front and centre of public campaigns and media interest and so forth can be pretty difficult at times. How have you handled the last few months, going from a position which was, acknowledged, but probably wasn't the most high-profile position in the state, to arguably the most recognisable face in South Australia at the moment? How's that impacted on you personally?
So I think, having had a long career also in clinical medicine, so I worked also as a paediatrician, so I'm very used to talking to members of the public, even if it's on a more personal basis with family members. So certainly when I go out and I'm doing the media, I really feel like I'm talking to people, right? And I also, in public health medicine, people might not have even known there was such a specialty, but there is a particular specialty called being public health physician. And one of our key competencies is dealing with the media and communicating. So when you're a doctor, you do a lot in terms of communication skills with your individual patient-doctor relationship. But as public health physicians, we're trained to communicate with members of the public. So I see it as part of my job, okay? So you wouldn't want the surgeon to question himself or herself when they're about to go in the operating theatre. So I just have a deep breath and I know I'm doing my job.
Yeah. And you've been really busy and as you said, working around the clock and so forth. How have you relaxed? How have you taken a breath?
I'm not one of those people that does a lot of relaxing, I have to say, because I really...
Did you enjoy the football?
Yeah, I didn't watch much of the football. I was so busy looking at how it was being organised, but I have my downtimes really... I love running, so I love doing trail running up in the Adelaide Hills, getting out in nature. So I do that mostly every day if I can, early in the morning, my head torch and the dog. So I think that's really important, that you have something that you can switch on and off. I'm just one of those people that enjoy kind of having that a bit of pressure on me most of the time.
You talk about COVID normal, and I think we understand that in the environment where the disease is still a real risk to us. Do you think this is going to have, even if there is a vaccine in the shorter term, longer term impacts on the way that we live? For instance, what I mean by that is, has South Australia had a unique, or Adelaide had a unique advantage in that we live further apart from each other? We're not locked up in apartments. We've got more room. Do you think that in the future will be a real benefit to a place like Adelaide?
I think you're really quite correct. I've been wondering, thinking why have we done so well here? I think there's a large number of reasons, but one of those is we're very lucky. We've got beautiful open spaces. We do have a metropolitan centre, and we might complain about the traffic and the public transport, but it's nothing like a large city where there is a lot more people milling around. We know with the virus it tends to be transmitted much more indoors where things are poorly ventilated. So we are very fortunate that we do have large open buildings and open spaces. And I know that not everybody lives in a huge house, but many of us do. And we don't have that, really close apartment living. It was seen very much in Singapore with their second wave when they had their migrant workers living in dormitories, and we've been sort of mindful of this sort of situation, maybe similar to correctional services for us, or nursing homes, or shared care accommodation. So those are the sorts of areas that we're thinking about in terms of our planning going forward as particular risk areas.
In March, when this really became a big deal and Dr. Murphy and the Prime Minister were on our TV screens most days, and yourself, the expectation was that we would have some virus in the community very regularly. We've sort of, in a sense, overachieved probably from what you thought, in a great way, obviously. Are you worried about the breakout, if it does happen, as it's happened in Melbourne, and how you communicate that with people, given that was probably the expectation back in March, but now maybe not? Yeah, no, we're in this very interesting sort of dilemma in a sense. And, I've said to people, we're almost the victim of our own success. So we didn't expect to get rid of it in the state, and WA ourselves, NT, quite early on, and I could feel more confident because we'd been doing such high levels of testing. Felt that at some point we didn't have that community transmission because we should have been getting cases otherwise attending our hospitals, for example. So that in a sense is this. People talk about the suppression strategy or the elimination strategy. And so New Zealand, for example, has very clearly had an elimination strategy. They're a small country. It's surrounded by sea. And so they've lifted their restrictions entirely. But it's still, you haven't got rid of it from the world. And so the way that we're doing this in South Australia is having a level of suppression and a level of restriction. We're making sure that we are testing. So if anybody's listening today and has a sore throat and a runny nose, I'm hoping that you're not at work, because you need to go straight to a COVID-19 clinic. And one of the things we're doing at the moment is looking at how we can make sure that it is as easy as possible for people to get that test done, because it's the only way we'll tell if we've got some cases starting up again. So we've got the border with Victoria. That's stressful for a lot of people. We would like to not have that in place. But let's see how we go over the next couple of weeks and see how things go in Victoria as well. But it as a country, we have very clearly got a suppression strategy. If we've eliminated in some states, that's a bonus. But we need to understand as a community, it hasn't gone away completely. Although I know that for many people it feels like it. Yeah, and obviously the border opening and more people move around, the more risk there will be for that breakout. Is winter a factor in this? We often talk about cold and flu season, and in the sort of depths of our winter, you always feel a bit, a bit more down and so forth.
Well, it doesn't mean that the virus happens to like winter or the cold weather more, but we do tend to spend more time together inside, and so you've got that opportunity for transmission. It's been predicted to be a cold, wet winter, so that may have some impact. I know that the European countries are feeling that there may be some relief for them in terms of their transmission because the weather's getting better, but we're not really building that into it in terms of it being a major factor. Yeah.
And usually, the expectation was when early on, if you've had it, then you were sort of COVID safe, to speak. Yeah. Is that the understanding of the virus? Are people able to get it twice, or are you seeing?
We don't know yet. We really don't know. The normal, not the normal, but there's the coronavirus that causes a common cold. We know that you can get it again. And it doesn't look like you develop a huge amount of immunity, but generally, we can do antibody testing and we can see that people do develop antibodies. Yeah. But this is one of the challenges with making a vaccine, is it may not be all that immunogenic as a virus, and so then the scientists who are making the vaccine need to look at how they can make it more their vaccine make a bigger immune response than you might get with a natural virus. Yeah.
You talked about at the beginning that this is the way we live and the ecology of the planet and so forth is influencing the amount of these coronaviruses and so forth. In a world where this may become a more common event, do you think there'll be out of this more emphasis for young doctors and medical professionals looking to study public health? Will there be more of an emphasis on public health, do you think, in coming years?
Oh, we certainly hope so, because this has been one of our challenges, is we're very keen to boost our numbers of staff, but there's not that depth in the workforce. And so, for example, our contact tracing team, when we've needed to increase that's needed to get onboarding but training for people because they may not have, they haven't had a background. We've pulled in medical students, nurses and public servants, and also people from PwC. So, but that wouldn't be something that they would naturally have that background. Look, I think this has been a wake-up call for not disinvesting in public health. Public health covers obviously communicable diseases, but the other areas that sit with my team are the disaster preparedness and resilience. So if there is a disaster like a bushfire or a flood or a cyber attack or anthrax gets dropped on us, all of these sorts of things, that's the team that does the planning. Now it's tiny, and we've needed to boost the numbers in that team. That is so critical from a public health point of view. In terms of being resilient to all of those sorts of things happening in the future. And it's the sort of thing that, because it's not there all the time, it's easy to go, well, cut that back because it doesn't look like we need it. Yeah. But we've seen this year with the bushfires and followed by the pandemic. The other areas in public health are things that people would just never think of. So when you turn on your tap, that you've got fresh water coming out and it's drinkable and it's not contaminated. That's not the case in every country. Septic tanks and sewerage, how is that disposed of correctly? So I have a team that work on that. Then there's food safety. When you go to a restaurant, you expect that you're not going to get a salmonella dose, So what's the systems in place? So all of those things in public health, we have a relatively small workforce, and we work with local government to ensure that those things are being done. And then there's the whole other side of chronic disease, so healthy, providing people with impetus to exercise and have healthy food, and then there's mental health and keeping our well-being. So there's a whole range of things that we can do to prevent people getting sick. That's why I'm doing it, because I much prefer to stop people getting sick than having to treat them at the end. Yeah. And when people think about health, they think about big hospitals. There's no point having a huge, lovely, shiny new hospital when water is contaminated to the population. You've probably, I don't know if you've seen that little cartoon when you've got the cliff and people falling over the cliff and the ambulance is waiting at the bottom to take them away. What I'd be much more interested in doing is putting the fence up around the top of the cliff and having signage and telling people to stay away.
Yeah. So staying away from the cliff, to use that analogy, in the next little while, explain to us, how does Victoria or Melbourne, the suburbs, what's the good scenario from here and what's the bad scenario?
Yeah, so the good scenario is the number of cases will start dropping. So we're helping out with their contact tracing. So our team here is doing it virtually. So they're ringing when they have a positive case. Melbourne will say, here's the contact details. Can you find them? So one of our team will be ringing, finding out their details, their close contacts, and then triggering those people need to be in quarantine and that case needs to stay isolated. So that the reason they've pulled in extra assistance from our state, Queensland, New South Wales, is that's the only way they can get on top of this. So they've done that lockdown, or however you want to call it, in those suburbs to try and stop the spread so that all this work can happen to stop those chains of transmission. And the quicker they can get hold of, the quicker you can test, treat and trace and quarantine, the quicker we'll get on top of it. If we can't do that quickly as a nation, it'll just get away from us.
Yeah. And in that scenario, that it then spreads more quickly in Melbourne.
Yes, and then that's a risk to the whole country. And the fact that we've lifted our restrictions means that it could take off here very quickly. Yeah. So I don't mean to scare people, but it's just kind of the reality.
That's been your last few months.
That's just the way it is. Yeah.
Looking back, and this is always a really hard question because the answer to this is inevitably yes, but it's hard to identify. But would you do anything differently? Has there been steps along the way where we could have done things you've learned from things we did early on, or it's such an evolving crisis?
Yes. Yeah, I mean, we definitely did the right thing closing the international borders. But if you can remember at the time, it was such a huge thing to do to stop people travelling into Australia. I remember being at AHPPC and just thinking, wow, this is just...
surreal.
It was surreal, but you could see what was happening overseas, and we really needed to do it.
Do you think that helped with the way that we've suppressed that there was this evidence on our TV screens, and particularly the New York evidence, which was so, confronting?
Yes. Well, I think we knew before that at HPPC, but we needed to turn the tap off, and because we only had these small teams of contact tracers, I don't know, there might have normally only been 15 in South Australia, and if that tap didn't get turned off, we would be in huge trouble because we wouldn't be able to keep on top of it. But it gave us time to increase our workforce. It gave us time to ramp up our testing. People may not recall, but many of the surgical masks in the world were produced in Wuhan. So we just couldn't get hold of them. And we had this prediction about the number of cases we'd be seeing, and we didn't have the PPE for our doctors. So this is another thing that we've now been able to put in place. We've got Detmold, a South Australian firm who's turned around what it does as a business and now is producing masks. We've got the universities, Flinders included, being a testing site for masks. And so we're in a really good position now, much, much better than we were early on. So that is a reassurance to people that we're now testing and such like. But everybody has to still do the right thing. It's no point me having SA pathology capability, but people not going and getting tested when they get a cold.
Have you been surprised by how compliant South Australians were in the lockdown and the way they've reacted?
I don't think I'd say surprised because, I just think we have a great community here. And I've worked, obviously, when I work as a paediatrician up at Flinders, I meet many members of the public and the community, and I had a sense that people would understand and they would get together and they would be able to do what was needed. Going forward, we know from evidence elsewhere it is more difficult if things happen a second time to be able to convince people. So we'll just have to see how we go. look, we're in a very good place at the moment. Yeah.
Is the fatigue factor a worry for you, that the if there is a breakout, people are fatigued with the lockdowns and under pressure with their finances and so forth, that they might not listen to the messages as much as they have previously?
I mean, that's obviously always going to be an issue. And look, let's just see how they go in Victoria. Victoria's problem is everybody's problem. This is why we've stood up and helped as much as we can. We're doing that as a nation. And look, I think we just have to see what happens from across the border. Yeah.
So part of these interviews is usually a series of questions from members interested in the topic, and there was a series of questions that came through, as you'd expect. Most of them, I must say, though, were more statements about thanking you for your service and so forth, and the way that you've communicated, and there was a stream of questions, which is probably a good way to finish on. Where are we going to be in 6 or 12 months' time?
Well, I've been quoted by the Premier to say I don't have a crystal ball, and it would be fabulous if I did. We just have to, I think, keep looking at the evidence, keep looking at the epidemiology, being vigilant. People washing their hands is so important. Staying 1.5 metres from each other is so important. I just walked down Piri Street to get here, and people are not possibly doing that to the same extent. And you can see why, because we haven't had any cases, and you can kind of just get relaxed about it. But it is something that we do need to keep doing. Somebody tried to shake my hand the other day coming to a meeting, and it was just like I just stood back, and they had, forgot, yeah. So it's trying to remember all of those sorts of things, not calling people out on it, but just kind of, trying to remember those things. Probably those two are very important, but not going out when you're sick and getting tested, because we can't respond from my team's perspective unless we are monitoring the disease. Yeah.
Thank you for your time. It's been a pleasure.
Thank you very much, Jamie.